Movement is Medicine webinar. Today, as Amanda mentioned, I'd like to cover how we can work on helping our patients preserve bone and joint health with body weight support technology. What we're going to do today is we'll review the benefits of physical therapy and exercise. We all probably know this for osteoarthritis and osteoporosis. We'll talk about body weight support and what it can do for those patient populations. We'll talk about how to adapt to insurance industry requirements or changing healthcare landscape, where we need to focus on outcomes, and how we as physical therapists can play a role in health, wellness, and injury prevention. So as physical therapists, I think we're in a really unique situation where we can treat not just acute conditions like ankle sprains, post-surgical conditions, but we really have a role in helping people with chronic conditions, chronic disease states. And if you didn't know, the Medicare just allowed treatment for peripheral vascular disease under the supervision of a physician. So usually in your hospital settings or your cardiac rehab facilities, you can get reimbursed now for treating peripheral vascular disease. And I think there are things like OA and osteoporosis, which as the population ages, you're going to have a larger and larger number of people with these conditions. They're going to require medical care and ways to kind of offset utilizing the system and our insurance monies. So I think we're in a very unique role as physical therapists to help not only these patients, but also the healthcare system. So what is osteoarthritis? So just a quick review. It's the most common chronic joint condition people will have. It afflicts over 27 million Americans. And the most commonly affected joints are the knees and the hips. It's basically a breakdown of cartilage. Osteoarthritis is, that wear and tear. Symptoms include pain in the joint that's affected, so usually hips again or knees. Swelling usually occurs in the joint. Because of pain and swelling, you get decreased movement, decreased range of motion, and then stiffness. It is progressive, so patients will notice the symptoms getting worse over time. They can ultimately lead to the need for surgical intervention. 1 in 4 adults will develop symptoms of hip osteoarthritis by age 85, and 1 in 2 adults will develop symptoms of knee OA in their lifetime. Many who have these symptoms feel the effects are inevitable, and then they just kind of wait for surgery, and that's part of our healthcare system as well. People that have pain, they're usually recommended medications by their physicians, right? You could take ibuprofen, you could take Celebrex. There's all these types of medications, and if that doesn't work, you've got injections, right? You've got anti-inflammatory injections. You've got now the Synvisc or hyaluronic acid to help with joints. So you've got all these kind of options to try and act as a band-aid for what's going on, when they should be getting physical therapy first and foremost to try and address any issues that they might have. Osteoarthritis can also have some negative effects because if the patient's not willing to move, then it may lead to some cardiovascular issues. It may not allow them to properly treat those conditions. So, we want to make sure people are moving. So sedentary lifestyle also encourages weight gain, obesity. And so we have that risk for diabetes, coronary artery disease, hypertension. And especially as the population ages and you get older, these are conditions that happen anyway. So if they're not able to exercise because of OA, then it kind of further promotes these secondary issues. The other thing that happens when people aren't quite as active is they become a falls risk. And for the elderly, that's a big issue. So we want to make sure people stay moving, they stay active, they can work on dynamic balance. So loading is important for cartilage. So when we talk about cartilage health and kind of treating OA, people do need to load it. The problem when people are in pain is they don't want to load it. We know that excessive loading can be detrimental. So a lot of running, people that have been doing a lot of pounding on their knees over time, with heavy weight activity without maintaining proper range of motion or flexibility, they can have excessive load on certain areas of their joints. Immobilization, and non-weight bearing might also be an issue. So we also see that we need to control those things. So if you're seated a lot, whether you're commuting, you're traveling with work, you're at a desk a lot, we want to make sure that you get up and you get active. You're not sitting a lot, immobilized. If you are, that also leads to cartilage wear and tear. So moderate exercise is beneficial. So if people are doing activity and covering the full range of motion in the joint, that's helpful. The data is insufficient though on how much they should do or how much they should load it. We don't really quite know that. We do know that if activity is not detrimental, then we can assume if the activity is not detrimental, it was pain-free. So we can assume if people don't feel pain in their joints and they're doing activity, taking it through the range of motion, that hopefully it's going to be helpful for the cartilage. Okay. So osteoporosis, yeah. Bone activity, we want to make sure that people are loading, because if there's an imbalance, then that's going to lead to osteoporosis. So osteoporosis affects approximately 54 million Americans. 1 in 4 men and 1 in 2 women age 50 and older will break a bone due to osteoporosis. So pretty high numbers that'll be impacting our healthcare system. It's a serious complication with the elderly, and the effect on the healthcare system is about $19 billion annually, related costs. The other thing that can happen with elderly, if they are in pain, if they are recovering, is they can be limited in their mobility. So that can lead to isolation, depression. It can also happen, especially if they have to be placed in a care home or skilled nursing facility for a period of time where they're away from family and loved ones. With bone, remodeling is constant throughout our life cycle. So it's not something that stops, but it's something that shifts, and so it may occur a little bit more as we're younger, as we're growing, and then it may change a little bit as we age. If osteoporosis is a concern, then medication can be applied to slow bone resorption or increase bone formation. The problem with medications, there can be side effects. They can interact with other issues. Again, if you're elderly, you're already taking high blood pressure medication or cardiovascular medication. You don't want to have another type of medication to add to that. If we think about Wolff's Law, we know that bone responds to the loads that are placed on it. If you place load on it, it'll remodel. So you need to make sure that you're doing enough activity to stimulate that bone. If you're sedentary, again, if all you do is sit at a desk, commute, as you get older, again, if you don't feel like you have good balance, if you are deconditioned, you may not want to be active. Weight bearing and muscle strengthening exercises can be used effectively. And so we definitely need to make sure that in elderly populations, they're again staying active. There's doing body weight exercises, they're loading. And the added benefit with working on close kinetic chain activities and loading bones is that they're also going to get benefits for balance, and that's going to decrease their falls risk. So let's help patients move. So let's get them going. That's our job as physical therapists, and that's why I think we're in a position where we can really help these populations, and even those who have other metabolic issues, conditions that require exercise. One of the reasons that a lot of elderly patients that have OA may not want to move is they're in pain. So when you're in pain, you don't move as much. If you don't move as much, you lose flexibility and strength. You don't take your joints through the full range of motion. That's going to lead to deconditioning, and then poor lower extremity mechanics. Well, then it leads to more pain because you're not moving, and then you get in this cycle. So what our role is as physical therapists is we can help break that cycle. If we encourage mobility, that's going to improve the flexibility and strength. That can maintain cartilage health or maintain loading on bones, which help to normalize gait and restore quality of life. So more movement is the key. and that's what we want to try to encourage patients to do. There are actually studies that support this, and I just want to highlight a few. This one done in 2016 took 78 patients that were on a waiting list to get arthroplasty, and it was hip or knee. And what they did was there was a control group which was received the standard medical care. They were waiting, and then there was an intervention group which during the waiting period, they went on and went through an exercise and education class with a physical therapist. With the intervention group, they saw significant improvement in the pain severity, and they were able to kind of, modify some activities leading up to the surgery. So exercise and education helps decrease pain in patients with hip and knee OA. In this study, also conducted in 2016, 126 participants that had knee OA, also comorbid conditions like heart conditions, diabetes, COPD, went through a 20-week individualized exercise program. They saw improvements in the WOMAC and the 6-minute walk test. And so this researchers saw that exercise can improve function and it's safe in patients with knee OA and severe comorbidities. So the key is to get people moving. If they can move better, function improves, and sometimes some of those other conditions will also improve. And in this one, for female patients that recovered from cancer, one of the issues that happens with chemotherapy is osteopenia and osteoporosis. So 18 of these patients completed the study. They went through an exercise program, 26 weeks, 1 hour per session, 3 times a week. And what they saw was with the supervised exercise, which consisted of cardio, circuit training, core exercises, that these subjects had improved bone mineral density throughout. So it wasn't just in certain bones, but in the spine, the hip, and the whole body. So exercise is effective at improving bone health and decreasing the risk of osteoporosis. So again, the theme is movement. People move, if they exercise, they can get through close kinetic chain activities without pain, it's going to prove beneficial. So oftentimes what leads to pain is gravity, is weight. So if we can eliminate some of gravity's effects, we can encourage people to move. And body weight support is used already with patients that have these conditions. So elderly patients that have OA, if they're painful, a lot of times physicians may recommend aquatic therapy. You can send them to a pool. They like that. Part of it is a social aspect. They can get in a pool with other patients. They can go to a class. But some people don't like that. They have to change. It's time consuming, especially for clinicians. If you have to supervise patients, then it's difficult to do that in a pool. You're removed from your clinic, removed from the space where you're treating other patients. Body weight support is great for decreasing stiffness and inflammation. You get better activity tolerance because the body weight support of the water, the buoyancy, removes joint compression. And then when you don't have the joint compression and pain, you're going to get better joint mobility. The thing is with water is because you're always in a certain level, you have a certain standard level of buoyancy and weight support. You can't really adjust it. So as people get stronger, maybe they need less body weight support. It's difficult to do in a pool. You can definitely provide benefits, and people can derive really, really great help from a pool. But if you want to challenge someone, if you want to give them a progression, that's a little bit more difficult to do. And so you want to encourage proper loading, making sure that they're getting enough. But if you need to take away the support so that you can give them more loading, you can do that as well. As they get stronger through their leg muscles, their lower extremities, that's going to provide more support from those ground reaction forces. So you don't always want to be at the same level of unweighting or unloading. So with the AlterG, we can do all those things mentioned with the benefits of body weight support, but we've got a couple other added benefits. With the AlterG, you can control loading from 20% body weight. You can take them all the way down to that, or they can go to full body weight, and you can do that in 1% increments. So people can go through a progression and they can be guided through the strengthening program, which is going to help them feel less pain in their knee when they're walking at full body weight. Decreasing stiffness and inflammation, very much the same things. As in a pool, if they get body weight support, they're going to get less joint compression force because there's less ground reaction force, so that they're going to get better motion, better movement. Better movement means better joint health. Better loading means better stimulation for bone. And so we want to make sure we do that for these types of patients. And then we can normalize that gait pattern. So if they get better range of motion, we could take them through a normal gait pattern. They're not going to be limping. They're not going to be just loading portions of cartilage. They can move through the whole range of the knee or the hip. And we can do this in a safe environment. So they don't have to worry about falling. In the AlterG, they can work on incline. They can work on speed. They can even walk backwards. So they can challenge themselves a little bit to kind of decrease those falls risks. So less pain means more gain. And we have some studies that show this. This study looked at 31 participants with increased body mass index and knee osteoarthritis. They did a 12-week walking program in the AlterG Anti-Gravity Treadmill. And what they saw with these patients is improvement in knee joint pain and increased function. They also saw an increase in thigh muscle strength. So that's where, if you're able to decrease the support, increase load, you want to try and do that. If they get better thigh muscle strength, better quad strength, then they may also be able to decrease the ground reaction forces when they're walking at full body weight. And so they also benefited by they didn't need as much body weight support. So we can give people progression so when they walk without the AlterG, they can be in less pain and they can improve their quality of life. So the AlterG Anti-Gravity Treadmill can be used to safely manage knee osteoarthritis and improve physical health. Proper loading is key. This is something we talked about with cartilage, and if you're overloading it or underloading it, those are detriments. So you want to make sure you're loading it properly. So in this study, we had 12 healthy subjects walk for 12 minutes on a treadmill, on our anti-gravity treadmill. They did 3 separate sessions, one at full body weight, one where they added body weight, and then one where they removed body weight. And what they measured here was serum cartilage oligomeric matrix protein. And that's typically something we see when people walk. And it's usually a measure of cartilage damage. So you hopefully don't have much of it if you're healthy. If you don't have good knee strength or quad strength, if you maybe put more pounding to your knees, then you'll see more of the serum cartilage oligomeric matrix protein, the comp. And so what they saw in the study was the comp was greatest after the session. 13% increase versus before. And then at 15 minutes, it had come down a little bit to 5%. So still a little bit more compared to the pre-activity measurement. And then it was greater for the 40% body weight, plus 40% versus the 40% body weight removed by 14%. So the AlterG Anti-Gravity Treadmill may help decrease the stress to the knees while maintaining a cardiovascular response. So if you're able to train someone at less than full body weight, you're going to get less comp, less cartilage damage, hopefully, so you can stress them in their cardiovascular system. And we do have studies that show that running in the AlterG is possible. If you're running at 50% body weight, the joint compression force inside the knee is the same as someone walking at full body weight. So you're able to increase the activity by working on speed or incline to get a cardiovascular response, but you're able to remove the impact on the knees by providing body weight support. So next I want to highlight this osteoarthritis case study. This was a 71-year-old active female. She had a meniscus tear, chondromalacia, and OA. And she reported the pain was 5 out of 10 when she went into PT. She wasn't able to hike, which is what she loved to do. She had difficulty with her ADLs. She started using AlterG at week 1. This was something that she requested to try and delay surgery. She didn't want to go through meniscectomy. She didn't want to do anything to the cartilage right away. She wanted to try physical therapy first. So that she was allowed to go through the sessions, selecting her body weight support based on her comfort level, making sure she was always pain-free. She was able to increase speed and body weight to get full range of motion to normalize that gait pattern. She also did some squats. some single leg stands, some step downs in the AlterG. Again, loading properly, but not overloading or underloading. And after 12 weeks of PT, the knee pain resolved. Not any pain after that. She was able to return to her hiking, about 90-minute hikes, so she was thrilled. And most importantly, surgery was avoided. So if you go to a surgeon, you go to a physician, that might be the first thing they recommend, when the first thing they should recommend is physical therapy. So I think, you know, as therapists, we hold a very important role in educating patients that they have a choice. If they go to the doctor is going to recommend what they know, and they're going to try to solve a structural issue. But a lot of times we know that with structural issues, what shows up on an MRI doesn't always correlate with what we see in our patients. They may present very differently. And that's where we come in as PTs. If we go through our full evaluation and find things that they can work on, and we treat those things, a lot of times the symptoms resolve. The pain disappears. Function improves. They don't have to get the surgery or the injection, or they don't have to take the medications. And that's something that is going to be more and more valuable in our healthcare landscape. Value is going to be important, because value is what saves people money. 12 visits of PT is, in the long run, going to be much cheaper than any surgical procedure or any physician's visits that patients will go through. Those functional measures reporting, the data is important. We need to have that information so that we can send it to insurance companies. And that can be now if you're trying to renegotiate your contracts, or it can be later to prove our value as physical therapists. So we need to provide quality and quantity. We need to treat volume of patients because of the reimbursement issues and also access issues, but also want to make sure we maintain quality so that we have great outcomes. So it's key that we do things that are functional. You know, gone are the days where you focus on pain. It's time to focus on movement, make sure we improve people's functional levels. Functional measures, we can use that data for insurance companies, for physicians, for patients. And for the elderly and people that have chronic diseases, like peripheral vascular disease, OA, osteoporosis, want to prevent functional decline. And then quality metrics. A lot of this is built in now to EMRs. If it's not, you just have to start collecting that data on your own with your functional measures so that you have a record. So make sure you're measuring functional tests. You know, whether it's the Berg, the dynamic gait index, timed up and go, lower extremity functional scale, FIM scores if you're in a SNF or a hospital. Make sure you can prove the functional improvement. And then with the AlterG Anti-Gravity Treadmill, we can put the fun back in functional. If someone's not in pain, they're going to want to do more. They're going to want to stand. They're going to work on balance. So in the AlterG, you don't have to turn on the treadmill. People can stand in there with body weight support. You can make them reach. They can work on dynamic balance. They can work on cervical rotation. They can march in place. So there's a lot of things they can do. They can work on strength, calf raises, squats, single limb stance, single limb squats, little lunges, pre-gait activities. So a lot of times neurological patients benefit from the AlterG because of the body weight support. And what I'll do is I'll make them load the hemi side, so the side that's affected, because they want to not load that a lot of times, or they're not aware of it. So I make them work on that a little bit before we start the treadmill. And that way, hopefully, we get a better gait pattern. And then most importantly, gait training. With the AlterG, we can work on walking, we can work on running. So if we want to get them back to functional, which is being able to walk safely so they can return home, there's nothing that's more similar to normal walking than the AlterG. Sure, they can walk in a pool, but the buoyancy of the water, the resistance of the water does not quite feel normal. In the AlterG, we can adjust the amount of support they get. So we can bring it down to just, providing 10% of support or 20% of support. We don't have to provide a lot, and that way it feels normal. And then gait challenges. Again, they can walk with cervical rotation. They can walk with reaching. You can change speeds on them. You can make them go backwards. So you can do different things to decrease their fall risk. As physical therapists, it's important for us to educate the public, to be teaching them that they have options outside of what the physician or surgeon may tell them. And I always tell patients, if they don't recommend physical therapy to you first, then you probably want to get a different opinion as well from your surgeon, right? Or from another surgeon. Because if the one that's recommending that you go right away to surgery or injections doesn't give you the option to go to physical therapy, which is more conservative, you might want to make sure that that's truly the solution for you as a patient. Is the surgery necessary? Or do you want to try physical therapy first and see what the outcome is? Because if you're going to have to undergo the knife and go through physical therapy and pain and recovery, then why don't you try the conservative method first? If it solves your issue, then you save yourself a lot of pain, time, and money. So there's a lot of stuff out there. You can, there's a lot of hashtags now on social media, websites, Instagrams for encouraging people to go to physical therapy. And so we need to educate the public, let them know what we can do. So host seminars, look at different places where you can do that. Some people do it at, hospitals, at senior facilities. Some people do it at gyms. You also think about commercial sites, a shoe store, running shoe store, specialty shoe store that might be near you that you can partner with. Those kind of facilities may have opportunities for you to reach out to their clientele. Develop walking programs. So you don't have to just be about physical therapy. You can do cash pay programs. So those people who have OA that have other comorbidities, again, can come in and use your AlterG. You can help them develop a walking program to help them focus on getting to their target heart rate. They can walk 2 to 3 days a week, and you can charge them cash to use the AlterG because they're not going to have access to that any other way. And that's going to help them not only control those comorbidities like coronary artery disease, hypertension, but it may avoid or delay the surgery altogether, like the case study that I showed you. And then if they are in physical therapy, transition them to a maintenance program. So they don't have to keep coming in for physical therapy. So that's another way for you to allow access to more patients, is that they can come in, do their physical therapy. Then when they get to a point where they're just using the treadmill for walking, for exercise, you transition to a maintenance program. Then they don't really need the oversight of the physical therapist constantly. They could possibly be supervised by one of the aides of the facility because it's more of a personal training or exercise visit. So you can come in and still use the AlterG for all these things, the cardiovascular health, the weight management, treating the OA, properly loading for osteoporosis, and they can provide cash revenue for your facility, but you as the PT won't have to supervise all these people. So those are some options and ideas to help us as physical therapists reach out to more of a patient population, more of the public. I think that's going to be more and more critical in our healthcare system. And I think a lot of clinics are seeing the benefits already. You have therapists that are focusing on cash pay, that aren't doing insurance. You have them reaching out, making sure patients understand why they need to make a choice about their healthcare. Why they can choose what's best for them. They don't have to rely solely on insurance or physicians. And so that's something that, if you can do, I think will help greatly in serving patients and serving the public and helping to let people know what physical therapy can do. So thank you all for joining us for this Moving is Medicine webinar. We're going to open it up to some questions now. You can type those into the chat box, and Amanda can read them out loud, and we'll provide you with some answers.
So thank you all for joining us. If you do have any questions, please be sure to put them in the chat or the Q&A box. The first question that we have coming in is whether or not, what is the suggested unweighting percentage that you recommend starting new patients on to measure their pain?
So I always start patients at 50% body weight, and just because that gives me the opportunity to go up or down. And again, if someone has OA, I want to make sure they're pain-free. So at 50%, if they still have pain, I can go down to 40%. If they have no pain, I can come up a little bit to 60%. My goal is to make sure they have just enough body weight support. My goal is not to make sure they're starting at the lightest weight possible, because if they can withstand a certain amount of load, again, with cartilage, they need to have load. if they can withstand loading for bone, they need to have stimulation according to Wolff's law. So I don't want to remove all the weight. I want to make sure that they're at a comfortable body weight. So I start at 50% and I go up or down based on the patient.
Thank you, Jacon. What types of activity do you recommend to these specifically osteoarthritis patients in between anti-gravity treadmill sessions?
So what I find when I see a lot of OA patients is that because of the pain, because of the amount of time they've been dealing with it, and they haven't been moving, they are actually very stiff and they're not very flexible. And so they're not taking their joints through a full range of motion. So you can imagine, you know, if a joint is limited, you're just going to get a lot of shearing, a lot of force on certain surfaces. So you got to make sure they get through as much of the range of motion as possible. So in between sessions, I'll have them work on some flexibility at home, maybe some, you know, static stretching if they're really, really tight, definitely some dynamic activities. If they're really, really painful, it doesn't have to be loaded right away. I just want to take them through the range of motion. So I might even start them with some open kinetic activities to kind of get them loosened up, but definitely trying to get their full range of motion. And if it's tolerable, you know, they can do other things on days that they're not in physical therapy, like yoga. They can practice, you know, if they're really tight and they want to practice stretching, but it's hard, they can get a massage before that. So I just try to make sure that I help restore as much of the range of motion as possible. And it's surprising how many people feel a lot better just doing that. And then once they understand it, they can work on it and monitor themselves in their home program.
Are there any recommended unloading progressions? I think this person is trying to get at whether or not there are recommended programs for unloading for patients or reloading patients at specific percentages throughout.
I try not to go more than 10% body weight a week, just because I want them to have a chance to adjust. Again, I don't want to cause pain, because if there's pain and inflammation, then we're going to go backwards. So I don't let them increase more than 10%. So even if they're, you know, say they're pain-free at 60%, and then they're using the AlterG the following week, you know, I let them go up to 70. But if they feel good at 70, I don't let them go up to 80 or 90, just because I don't want to cause inflammation. So I make sure they don't go too fast. And then I also focus more on the walking speed, maybe incline, before I change loading. So when someone's in the AlterG and I know that they're pain-free at 60% body weight, I will challenge them to try to take bigger steps. Again, because if they're getting better hip extension, then maybe they're stretching out those hip joints, hip muscles. So you're taking it through the full range of motion versus a smaller gait pattern, and you're just loading cartilage in a certain range. So the progression would be no more than 10% each week, and then make sure you work on speed and the kinematics before you work on loading.
Great, thank you, Jacon. The final question that we have right now is measurements. What can the anti-gravity treadmill measure? You've talked about being able to use some of that information.
Well, the anti-gravity treadmill really measures body weight support. And so with that, you can let your physician know that, you know, my patient, you know, Joe Smith, you know, can only tolerate 60% body weight. So we're going to need to continue physical therapy, because if they're not at closer to 80 to 90% body weight, then they're not going to be comfortable in an overground situation. So that's one thing that the AlterG can measure. We also have our Stride Smart technology, which is an accessory that you can add on to the anti-gravity treadmill. And the Stride Smart lets you measure things like weight-bearing symmetry, you know, stance time symmetry, step length. So you can really look at those gait metrics. Again, you can provide that to the physicians and insurance companies. But as far as functional outcomes measures, those are separate things that you'll have to do either through your EMR or through your own clinic. And those are the outcomes. Those things are what insurance companies want to see.
Wonderful. Jacon, thank you so much for your time. And thank all of you for joining us today.